Welcome back to our second part on blood. And with blood, we just got done with our red blood cells, so now we'll begin in our white blood cells. So, white blood cells or leukocytes are the next component of our formed cells that we have in the blood, and so part of our formed component that is there. We have many less white blood cells than we do that of the red blood cells, and so they're going to make up a very small amount. So when we look at a blood smear of the blood, we're going to see many red blood cells and just kind of dotted here and there with white blood cells. And if you remember back to when we did the spinning down of the blood and looked at the different components of blood itself, we saw that we only had about 1% of the total blood volume was white blood cells, the majority of it being plasma and red blood cells taking up all the rest of it. One of the unique components of white blood cells is that they can leave the capillaries. So they have the ability to, in a sense, as the term implies, walk out of the blood vessels. And so they're going to be able to do diapedesis there. As they move from the red blood or from the blood vessels, leaving the red blood cells behind, they're going to move through the tissue spaces into the extracellular spaces and search out whatever it is that they are trying to defend the body against. And so they're going to be finding all of those antigens to attack within the body itself. WBCs, in terms of our count, are going to be in the neighborhood of 11,000 cells per cubic milliliter. So quite a bit less than that of the red blood cells as well. And if we have any kind of bacterial, viral, parasite, whatever type of infection that may be going on, those levels are going to start to become elevated on there. And so we're going to see those levels start to head up above and north of that 11,000 number. For white blood cells, we divide them up into two major categories, either granulocytes or agranulocytes. And what this comes down to essentially is how we see them in a blood stain smear itself. And so when it comes to those that are granulocytes, when we look inside their cytoplasm, we start to see little granules. And so we're going to see cytoplasmic granules inside. Essentially what this comes down to is we're going to see almost what looks like little grains of sand or something inside the cells themselves that are there. And so when we use right stain, we're going to get both acidic and basic types of staining that are there. Some of them may even have both of them. And so we're going to see red and blues as far as the colors go inside of those, and purples inside of those granulocytes themselves that are there. The granulocytes themselves tend to be bigger, so we get much larger cells that are there, but they stick around relatively short amount of time, especially when compared to the RBCs. And so whereas the red blood cells, we may get a few months out of those red blood cells, the white blood cells, we're really getting just days. So the first of those, we have our neutrophils. And right off the bat, we can see that inside the cytoplasm there, it doesn't look nice and kind of clear. It has all of those granules inside. And so this one takes up both an acidic and basic dye using our right stain. And in that process, we're going to get this kind of a purplish color inside the cytoplasm. And so kind of a lilac type of a color, or a light purple type of a color to it. One of the other large things that we can see with a neutrophil is the nucleus. That nucleus itself is not just a big round circle, but it is a multi-lobed nucleus that is there. And so we're going to see that nucleus have many different shapes to it, but it's going to look like it has kind of big lobes or big kind of outswellings, followed by where it tapers down, and then it gets big again, and then tapers down in between those as well. We're going to use neutrophils as a large component when we have a bacterial infection. And so they're going to be able to consume those bacteria via phagocytosis. Next up, we have eosinophils. Eosinophils are one of the lower numbers in terms of the overall numbers of white blood cells. Neutrophils being the greatest. We see the highest quantity of those in our blood smear. Eosinophils being one of the lower numbers, and so they come in and around 3% or so of the total numbers of white blood cells that we have. This one is interesting because it tends to stain very red in the cytoplasm. And so you get a very, very red kind of appearance to the cytoplasm itself. Oftentimes even the nucleus can look a bit red when it is stained. Eosinophils are in low numbers, and part of the reason is because essentially one of their main jobs is parasites. And so parasitic worms is the big thing that it is going to become elevated in their numbers when we do have a parasitic infection. The other time that we'll see them is after somebody has allergies. It's going to start to break down that immune complex. And so it's going to start to break down the allergic response that is there and start to lessen the overall allergic reaction as well. Next up, we have our basophils. Basophils are the least numerous of all of our white blood cells. And so they come in at less than 1% of all of the white blood cells. If we were looking on a microscope slide of the white blood cell or of the blood, it would be difficult to find a basophil. And so if we were counting 100 cells, we might find one. And so we may not even find a single cell in that particular area of the slide itself that's there. The basophils have very, very dark staining granules. They do stain quite dark, and they often are able to essentially cover up the shape and the even visibility of the nucleus that we have. But the nucleus does tend to be in either a U or an S shape, and it tends to have we can kind of see it in here, where we have 2 or 3 different little constrictions where it kind of squeezes down on those. Basophils are there when we have an allergic reaction. All of those little purple granules are containing histamine. So when we have an allergic response, those basophils are going to come along. They're going to dump all of that histamine out into the area, and we're going to start to have an inflammatory response. And so we're going to start to have the components that go there in terms of causing red blood vessels to dilate. We're going to see smooth muscles start to constrict in other places, like the windpipe. And so those have that effect on it. To counter the effects of histamine, this is where those nice antihistamines come in for allergies. They're going to block those histamines themselves. Next up, we have our 2 agranulocytes. And so these ones do not have any visible cytoplasmic granules. These ones are going to be basically clear inside the cytoplasm itself. It's going to be nice and purpley colored or pink colored in terms of its cytoplasm goes. And then with the agranulocytes, the nucleus of each is relatively distinctive in terms of its shape. Our lymphocytes have a nice spherical, basically an entire circle. It tends to take up almost the entire inside of the cell. And then our monocytes have, excuse me, have either a kidney bean shaped or a U-shaped type of nucleus. And so it has kind of a U shape to it, or a kidney bean appearance to that particular nucleus. So here we have a lymphocyte. Again, we have this very large spherical type of a nucleus inside there that takes up the majority of the inside of the cell. What's left of it, it usually almost looks like a crescent moon shape in terms of the overall cell. And so if we look at this part as being kind of the actual moon that we can see, and the dark area being the spot that we can't see on the moon, gives us that nice kind of crescent moon shape to it. Lymphocytes are going to become elevated when we have viral infections. So these are going to become elevated whenever we have a viral type of an infection. And lymphocytes come in 2 varieties. We have either T cells or we have B cells. And so we're going to have 2 types of them. They get their names based upon where they have become matured. And so the T cells are going to be from the thymus, and the B cells are from the bone marrow. And so we have 2 different originations there. They also function completely different as well. And so T cells give an active immune response. They're going to go out and essentially try and destroy the virally infected cells themselves. Whereas B cells are going to give us antibodies. So they're going to differentiate into plasma cells. They're going to get us our antibodies from there, and then we're going to have our ability to recognize them and also create antigen antibody complexes to bind up those antigens themselves. And so this is where we're going to get our memory from our viral types of infections. Monocytes are the largest of our white blood cells, and you can see it has kind of like a U to a bean-shaped type of a nucleus that it has there. In the particular picture, we don't really see any red blood cells, but we may get 3 to potentially even 4 red blood cells to take up the space of that one monocyte. So they are quite large cells that are there. And monocytes are kind of like the scavenger, so to speak. They're going to be there for many, many different kinds of infections. And so they're going to be there for all kinds of infections because they're going to differentiate into macrophages. So they're going to be able to essentially gobble up our viral infected cells. They're going to be able to get rid of our bacterial infections, albeit slow. Same thing with fungal infections. They're going to come around when you do something like sprain your ankle, things like that. They're going to clean up the area afterwards. They're kind of a general purpose type of a cell that is there. So they are actively phagocytic, so they are going to consume whatever it is that is around them. And so anything that in a sense is not a normal antigen, they're going to get rid of, whether that's damaged tissue, whether that's infected tissues or foreign cells. It doesn't really matter to the monocyte. It's going to help to get rid of it. So here we have just a little mnemonic to remember the white blood cells numbers as far as their relative percentage in the blood. And these are not specific numbers per se. These are just some general rule of thumb. So never let my engine blow, 603830. And the first letter of each of the words in the saying goes with the first letter of the white blood cells. And then the numbers go along in the same order. And so we have a relative percentage of 60% neutrophils, 30% lymphocytes, 8% monocytes, 3% eosinophils, and obviously we can't really have only 0% of our basophils, but this gets us a good picture. Every lab is going to be a little bit different, but it gives us a good idea, a general idea for where those numbers should be. Next couple slides here, we just have kind of a comparison of the cells themselves, of all of our formed elements that we have within the body itself. So we already talked about the red blood cells. We then have our white blood cells and our granulocytes, and then our agranulocytes. Goes along the general size for them, who they go after as far as their function. So what kinds of infection are they going to become elevated in, or what kind of a scenario are they going to become elevated in as well. And then the last one here we haven't talked about yet, but we will in just a moment. We have the platelets. And so these are going to be the last formed element that we have inside the blood that we have to deal with as well. So white blood cells, just like with red blood cells, in a sense, kind of things can go wrong. And so we have different types of leukocyte disorders. One of the more common and kind of well known are leukemias in general. And so leukemias are where we end up getting an abnormal production of the white blood cells themselves. And in general, these fall under 2 kind of categories in a sense. We can talk about them as far as the types of cells that are involved. And so we have myelocytic leukemia. This involves the stem cells are myeloblasts. And then we also have lymphocytic leukemias, and those involve the production of lymphocytes on those. In addition to kind of the origin of the cells, we also have the type based upon kind of where the cell production has become overrun. And so we have acute leukemias, and then we have chronic leukemias. Acute leukemias typically gets us into these myeloblasts. We have many of the myeloblasts being formed, and in terms of the blast cells there. And so we end up with acute myelogenous leukemia or acute lymphocytic leukemia, so AML or ALL. And then we also get chronic myelogenous leukemia or chronic lymphocytic leukemia. And so 4 general types there that we can have. The acutes tend to be in the young. So these are usually kids that end up with it. And then the chronic leukemias are more prevalent in the adult. Doesn't mean that a child can't get a chronic type and an adult can't get an acute type either, but those are the general rules when it comes to leukemias. And so with leukemia, it's not necessarily that they don't have the white blood cells, but the white blood cells themselves are immature. So they're not going to be functional. So they may end up with large amounts of those cells, but they're just not functional for the body. And so what we end up having here is the bone marrow is being crowded out by all of these cancerous leukocytes. And so we have large amounts of them. Some of them are being produced all the way into the bloodstream, so they get out into the bloodstream. But again, they're not functional. They're not going to be able to do their job once it's there. If untreated, death is oftentimes going to be caused by hemorrhage of some kind, or more so oftentimes infection. So because they have all of these immature cells, they're not going to be able to fend off any kind of infection that is there. Treatment, leukemia is one of the actual treatable types of cancers, and this essentially involves a bone marrow transplant. And so they're going to have to kill off the old bone marrow, so it's going to involve destroying those cells with irradiation or chemotherapy, and destroy those cells, and then bring in new bone marrow to replace it and get that to reproduce new white blood cells once again, and red blood cells. So the last of our formed elements are the platelets. And platelets are, although they are formed elements, they are not whole cells. And so these are fragments of cells called megakaryocytes. And so megakaryocytes give off, in a sense, kind of pieces of themselves. And inside those pieces, they contain a few different things. And so they have serotonin, calcium, some assorted enzymes within them. They have ADP and platelet-derived growth factor inside there. These function as clotting factors, and so these are going to feed back into the clotting process, which is what we'll talk about in the next set of slides as well. There. And so the platelets kind of do a double-pronged kind of effect when it comes to forming a clot. They're going to, in a sense, kind of form a plug. And so they're going to create a temporary plug that basically kind of clogs up the hole in the blood vessel. And so if we have a blood vessel that has an opening in it, if we can get these little platelets to come in here and kind of clog up the hole, we can start to slow down the bleeding. Once they're there, they're then going to start to release our serotonin, calcium into the bloodstream from those cells. That kind of trickles along in the bloodstream, and that's going to help with bringing in more of those platelets, as well as helping the clotting cascade itself. And so they're not really involved in the formation of the part of the clot that is going to actually bind and kind of close things in within the cell, but they're going to help to kind of fill the hole temporarily. So they're the beginning part of the general process itself that are there. Platelets in the bloodstream are essentially not activated until they start to hit collagen fibers coming out of that cell. Part of their inactivation component is nitric oxide and prostaglandin I2. And so we have those components that are there that are going to keep it inactive until they hit those collagen fibers. And we'll talk about that next time in the clotting cascade. So for our coagulation there. So the production of a platelet comes down to, we have our hemocytoblast, our original in a sense, stem cell for our blood cells. That forms a megakaryocyte. And so we have our kind of intermediates there, our megakaryoblast, our promegakaryocyte, and then our final kind of mature cell, we have our megakaryocyte there. And it is just kind of giving off little pieces of itself. Those little pieces become the platelets. The platelets then end up into the blood vessels. And within the blood vessels, they're then going to float around until they potentially come across a broken blood vessel. Once they hit that broken blood vessel, they're going to get stuck to collagen fibers in that blood vessel, and they're going to start to form that platelet plug. And that's what we'll be talking about next time when we start to talk about coagulation.